Hello and welcome to the Surgical Spirit podcast. I'm your host, Dr. Al-hakim, the Third Eye Doctor. Pull up a chair and get ready for some candid and uncompromising discussion with experts, innovators, agitators, and influential people from every corner of health and well-being. From inside the hospital to at home in the kitchen, we're leaving no stone unturned in our quest to uncover the secrets of healthier, happier, more successful, and less stressful lives. Thank you so much for joining us, and without further ado, let's meet this episode's guest. Hello, Dr. Manjiri. How are you doing today?
I'm good. How are you?
I'm very well. We've got this funny kind of American accent woman saying something like the recorded has started. It's a bit irritating, I must say. But I mean, it's all about I guess permission and sort of people being informed, and we were having a discussion before we started today about maybe people are being a bit too well informed about all sorts of things.
Yeah, information is rampant, isn't it, in this day and age? It's getting the correct information that's the trouble, I think.
Yeah, and this is where sort of we come in, I guess, is that where they're trying to shuffle through all the different misinformation and try and give our patients the best information and the most accurate information. But unfortunately, we are lone voices, compared to a bigger voice out there, i.e. the media, and more importantly the social media, which is having such a massive influence on our thought processes, emotions, psyches. I don't know what you want to call it.
Yeah, absolutely. Difficult to sift out, I think, for the average person, what's true and what isn't true. Everything looks the same on a Google search, doesn't it? Looks equally important. And I guess as medics, we are sort of more inclined to look at things like evidence and studies and sort of the science behind it. But people are more about emotion. People are about what speaks to them and intuition and those kind of more basic feelings. So you have to kind of coat the science in something that people understand, make it relevant. So that's always quite tricky, I think.
Now you had a GP school, which sounds really sort of cool and really sort of high up there in the in the sort of hierarchy, so to speak. Where does emotion sort of come into training for GPs and sort of all these so-called inverted commas soft skills?
Oh, that's a good question, actually. I mean, pretty much general practice is about the soft skills. I mean, obviously there is science and there's differential diagnoses and there's spotting an ill patient quickly. But actually a lot of what we do is reassure patients and communicate with them. There's a little bit of counselling involved in it. So pretty much what we do in GP training is getting trainees to think about the softer skills of communicating with that person in front of you, which is no different to communicating with a friend or a colleague, but obviously with the added stress, I guess, of people being ill and what that means to them. And as we were talking about feelings of stress and anxiety that brings to the consultation. So part of the GP school is making sure the people that are training our GP trainees have the right skills to do that. So emotion is a big part of it, because I'm a trainer and that's how I got into this job. And being an educational supervisor or trainer, you have to love it. You have to enjoy being with those trainees, teaching them skills, facilitating them, getting them to enjoy general practice, I think. So that's part of it. It's an emotional kind of sort of thing, rather than it just being, I'd like to teach them a few things about hypertension. It doesn't kind of quite work that way. Most of general practice is soft skills. But yeah, we all love communication skills. We're obsessed with them in general practice, and teaching that, getting the trainees to get better and better as they go through is one of the things. So yeah, part of the GP school, I think, is getting more people into the fold to train, to become educators. And a lot of people really enjoy education, and if they have good mentors, they're more likely to go into it themselves when they qualify. So it's sort of the cycle carries on. So that's where the emotion comes into it. But there's also the emotion of the trainees. You know, they're human beings, as we all are, and they bring whatever is going on in their lives into their day-to-day work. It's difficult to separate it out. So we have to help our trainees, support them, you know, offer occupational health services. Certainly over COVID, extremely difficult for a lot of trainees, you know, having to be redeployed into specialities that they thought they had finished doing, seeing kind of a lot of death and illness, really. And also their own personal lives. They may have had things going on in their personal lives, people being unwell, families being unwell, families being far away. We've got a lot of trainees who have come from countries abroad. Yeah, so supporting them, sort of pastoral care as well as sort of the educational care, really. So yeah, emotion is part and parcel of everything we do, I think, as doctors, personally.
I mean, is this sort of more explicit now, whereas before it was more of an implicit, you know, way of, you know, delivering mentorship and apprenticeship? Has it become more explicit now?
Yeah, I think it definitely has. I mean, and there were some maybe educators that were naturally doing that without sort of being told how to do it. They were just sort of in that zone themselves. However, now there's a lot of things that we offer both our trainees and our educators, courses, help with well-being, and we actually have a professional support and wellbeing service as part of the deaneries that basically offer support to the trainees. So it's anything from career coaching, communication skills, sort of just coaching through difficult times in their lives. And then also there's all the external support that's offered, things like practitioner health stuff through the BMA. And I think this generation are very clued up about mental health and well-being and sort of what their boundaries are, which maybe my generation weren't as good at kind of setting the boundaries about where do you stop work, where do you start play, how do I stop myself from being overworked? I think we're all getting better at it, but I think this generation is definitely better at it because they've just had so much information about it right from day one. And not to be afraid to say that I'm not coping or that actually this is enough and I need some help. And I think that's important, that old school mentality of work, 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 and don't say when things are kind of falling apart actually is hopefully going, I think. And
do you think the stigma
good.
is changing, you know, beneficially?
It is. I mean, it's always a slow process, this kind of stuff, isn't it? It's not a sudden change. It's a small stepwise change. And I think it is changing gradually. I mean, there's still some people that will say the old ways are the better ways. And I think, you know, we can't stay as we were. Things are constantly changing. So I think we can learn from how this current generation separate work and life and how they keep their work-life balance. And I think my generation could probably learn from that a little bit and be healthier with it. So I think we all learn from each other. And yeah, definitely it's more explicit now in a lot of our training and in the curriculum. We offer a lot more support, I think. Yeah. Absolutely.
And is there anything like from the old days that you miss, or you think, you know, that should come back, or you think to yourself, we should bring this back in, you know, into our school?
Oh gosh, I think there are some things that have changed which may not be for the better, but had to change because of circumstances. I mean, I don't know when you were training what happened, but when I was training, we did very long hours, but we had firms. So we stuck with we had a group of people in the hospital that we knew really well. And kind of they were your kind of mentors, your buddies, and it ranged from your house officer, SHOs, all the way up to registrars and senior registrars and the consultant. And you all knew each other really well. You knew the patients really well because you looked after them as teams. And there was a real sense of camaraderie. And you'd go to work, and even though it was long hours, you knew people you knew were on call with you. You had that support, which was a physical and a mental health support. And so even though you were working long hours, it felt like you were well supported during those long hours. So I think the feelings of going to work were different. I feel sometimes now there's a lot of shift work. People go in, they do their work, they come home, they don't know who they're working with on a day-to-day basis. The patient list changes. It's really fragmented. And obviously some of that was the junior doctors contract and the European Working Time Directive, which obviously had to come in. But I don't know whether that somehow they could change that so that you get that support from your work colleagues. I mean, we all know how important it is that our work colleagues are our teams. And when we go in, we know that someone's having a bad day, we can all support each other. And certainly in my practice, that's how I feel. It's a fantastic team. It's a fantastic practice. We all muck in. If someone's having a very long surgery, we'll pick out things from their surgery that we can bring patients will see. We all, at the end of the day, we all go, are you all here? Are you all okay? Who's got any patients left? Let's take someone's patients and through the day. So that's how we all get through it, because we know if we're struggling, someone will support us. And I'm not sure that a lot of our trainees and junior doctors necessarily feel that way. So how can we get that feeling of camaraderie back without necessarily going back to doing, 4 or 5 days on call without rest? I don't know, but that would be lovely. I think teams are important and people are important to work with.
Yeah. The whole concepts around routine is absolutely important, particularly in very stressful situations and stressful work environments, and having, so to score, we can call it a second family, so to speak. Within this sort of situation, allows us to go that extra mile and sort of do that sort of extra shift, or see that extra patient, or just push the boat out a bit more. Maybe it might come back in a more sort of descriptive or controlled environment, or something that can be experienced, so to speak. So at least when they do become independent practitioners, or the future leaders, they know that this actually does work, and it has helped us a lot. So maybe we can inspire the next generation to think about these things.
Yeah, absolutely. I think it's worth thinking about not throwing out the baby with the bathwater, and thinking about the things that worked well, but the things that need to change, and try and amalgamate those so you make a better system. But it's very tricky, I agree. The NHS is a massive kind of organisation, and so many cogs in that wheel. How to make it all run smoothly and ensure everyone is well supported, whilst still needing the service element of, people need to be seen, patients need to be seen, particularly over COVID. I think this is going to be a real problem, something that kind of at every level of the NHS, people are going to be thinking, how do we move forward really from the last couple of years?
Isn't it just too big and, just too old? The system's too old. It needs to, essentially needs to break down into smaller functioning units.
Yeah, absolutely. I mean, GP practices, I guess, are not as big as trusts. So we do function as a smaller unit on the contract. So I think practices can respond within themselves and the PCNs now, as they are more responsively to things that are thrown at them, because they're a smaller unit. But there are still a lot of restrictions because of the way the NHS contract is set up. So however, within a practice, there's a lot of flexibility, and we can set up things how we may think is ideal for patients, for example. So I think that's why, the way GP set up works really well. And if we lose that and it becomes a bigger sort of corporate environment, we might lose that ability to very quickly respond, like they did with the vaccinations. I mean, it was so quick, and very quickly we're able to sort of set up COVID vaccinations for all our patients, and whilst carrying on delivering normal services, because we're used to doing that. We're used to be able to seeing what our patients need and how do we set that up for our patients within our locality. The bigger you get, the more wieldy things become, because it has to run through several layers of bureaucracy and hierarchy before you get the say-so. So yeah, how do we, I think the plan is to go to more community-based services, isn't it, to allow that little bit of flexibility to deliver what local populations need. And I think that is the way forward. But you're right, the NHS is a very old organisation. When it was set up, you know, people didn't live till the age of 100 with multiple comorbidities, and we didn't have as many medicines as we have now, and kind of evidence of using them. So yeah, you're absolutely right. A sea change, and what that is, who we could.
Yeah. I mean, you know, it does need a lot of courage from leadership to actually step up and say, well, this isn't working, and I think this particular model which I'm doing in my local area is actually working much more better than, you know, top down sort of, you know, heavy down sort of structures. And I think that's maybe where the change can come from. Or, you know, as you said, there is a kind of amalgamation between the young and the old, so that the young show us how to go forward. And I think that's probably, you know, where most change will come from. You know, this sort of amalgamation between young and old, and slow and fast, you know, us being the slow, of course.
Yeah, absolutely.
You know, there is a potential for change there, you know, profound change, but it needs, you know, it does need acceptance from all stakeholders. That's the thing, isn't it?
And that's so difficult because everyone is coming at it from their own angle, obviously. I mean, the integrated care systems that are being set up, the idea was to try and get primary and secondary care and community care working together to think about their local population. But with all these things,
where are the barriers in that?
The barriers are, I guess, setting up anything new. You are getting to know your teams, and a lot of it is actually understanding what the other people are seeing and doing and where they're coming from. So it's that those lines of communication have to be open and understand, well, what are your issues? What are our issues? What are the patient's needs? And how do we amalgamate those to come to some sort of kind of halfway house? And also, I think the issue is needs rather than wants, and that's the difficult bit. There's a lot of wants that we cannot fulfill in the NHS as it stands with the funding, and we have to prioritise need. The people who need it need to get the care. And how do we ascertain that need? How do we make it fair that everyone can tell us what they need, and then we can prioritise that? Because it doesn't always work that way. It's sometimes the people that shout the loudest may get care quicker or you know, easier than those who don't actually shout the loudest and remain in the background till it's absolutely needed. And so there is a bit of a problem with how we get that going. And I think the service was set up, as we said, in the 1940s for a different population and different needs. And that needs to be kind of really looked at as to what is the NHS able to cover? You know, what are we able to deliver as part of social care and healthcare? Is it reasonable to deliver all services to everyone? Or do we need to look at what are the core things we need to deliver and that everyone should have? And then what things can be added on as extras, you know, and I don't want anything privatized. I think we have got an amazing system, and to be able to access it regardless of who you are, where you're from, how much money you have, is really great. It levels the playing field and helps the economy, I think, because you don't have to worry about, you know, what you're earning. You can still get yourself treated and get back to work and look after your family. But there is a threshold that we will have to think about, I think, to keep the service running. Those are the difficult conversations, and I'm not sure that leadership want to have those necessarily, because they are difficult conversations and not everyone likes what they hear.
I mean, it does mean that there may be a need for change in leadership, and hence, you know, them not having that conversation, because it does take, I'll go back to courage again. It does take a courageous person to make those difficult decisions, because you're going against essentially an old culture that we've all taken for granted, and changing culture, you know, taking for granted culture is actually quite difficult to change, and it does take a real pioneer person to change that culture. But I think, having these discussions are really important, and actually asking those difficult questions, and then allowing maybe the private sector to come up with solutions to deal with these problems, because I'm sure there's lots of very efficient ways of delivering needs healthcare in a very cheap and efficient way, particularly with the technology that we have. I mean, if Elon Musk can go to space, I'm sure we can find a way of delivering really effective, cheap, and easy healthcare to a very large population. And as you said, people are clued up now. You don't need to explain much to them. You just need to guide them in the right direction. I think that's where, I mean, it's a bit like coaching, really. Coaching is really about facilitating.
Yeah.
And maybe that's where the future of healthcare is. It's sort of going down the sort of the coaching sphere of facilitation.
Yeah, absolutely. I think you're right about things like technology and innovation. I mean, what COVID has taught us, I mean, the general practice very quickly went digital there was a planned digital rollout supposed to happen April last year, and it's amazing. And a lot of people were a bit worried about it. But actually, because of COVID, it sort of all happened ASAP. Within a week or two, everyone had to go digital. And now, obviously, there's a call to go back to face-to-face. And actually, what a lot of GPs are saying is that the digital change has allowed us to deal with the numbers of patients that we would ordinarily not have been able to deal with.
Yeah.
And actually, if we go back to seeing everyone face-to-face on demand, the number that we can see will go down. And actually, there'll be more people dissatisfied with the service. I mean, we're speaking and seeing on videos and face-to-face more than we've ever done in total appointments-wise than ever before, even pre-pandemic. And there's a real shortage of GPs and doctors generally. So I
mean, why is there this kind of disrespect towards GPs' judgment and opinion about what's needed for their patients and patients' health?
I think we were talking about the media and sort of kind of the journalism that sort of fires up kind of people's anxieties and neuroses, and I think that has been a major part of it. If we had support from the government and from the media, that actually we're doing a good job, and lots of our patients have fed back to us that we're doing a great job, and they love having the phone consultations because they can be at work, either working from home or somewhere else. We can speak to them. We can do a video consult if needed. And then if we think they need to be seen, we can either see them on the day if it's urgent, or we can bring them in on a different day. And it's fantastic, but a large proportion, we've been able to deal with them over the phone and in a very good way with all the skills that we already have. And the survey that came back recently, GP surveys, patient satisfaction was extremely high. Our practice got something like 95%. And that kind of stuff isn't back in the media, that actually look at this, look at what we've managed to do. And I think the rhetoric that comes out is we're sitting at home saving our own sort of backsides because we don't want to see patients with COVID. And that's all it is. And actually, we're not. We're in work. We're physically going to work, but we're doing a mixture of different types of consultations. And we're seeing and dealing with more patients than ever before. And so I think the problem is it's a bit like the fuel crisis, that if you whip up enough frenzy, then there will be enough people that will agree with you. But that doesn't mean that that's the majority of patients that agree with them. And so I think it's an interesting thing about why people in the NHS are treated this way, because I think we're very visible and we're the first port of call for most patients. We're seen a lot. So, it's easy. It's a bit like, when you go home, the person that you take out most of your stress on is your spouse, because they're there and they're always going to be with you and they're never going to leave you. So, potentially, but so they're a safe space. And I think sometimes for a lot of the country, the GP is the safe space. We've always been there. We're here now. We'll always be there. So we're the first person they see, and possibly the last person they see. So it's very easy to use us as a scapegoat. And actually the reality is that a lot of our patients are extremely happy with the service. And I think we're seeing something like 50%, between 50 and 60% of patients face-to-face. And pre-pandemic, it was 80%. But we are seeing a lot more patients overall, in the sense that we are seeing and dealing with a lot more patients. So I think the service is robust. However, we don't have enough GPs. So we do need to work out, how are we going to sustain this service? As we said, the NHS, you know, we're free at the point of call. Whether you see us once a year or you see us 20 times a year, we are paid the same amount of money for that patient. So actually, it's a fantastic value for money service. You know, not many countries have that. So yeah, very sad that the media portray us as they do. But as GPs, we all know our own patients always give us, you know, feedback, and the feedback is always good. So, and if it wasn't good, then we tweak the service till we get, you know, we get the service that patients need in our locality. So yeah, it's very disheartening. And as we were saying, you know, I've stopped reading kind of things because in the press, because it's actually very demoralizing for our team, and we don't want to read that kind of stuff. It doesn't help us do our job better, really, at the end of the day.
Yeah, I mean, what kind of changes do you want to see? I mean, do you want to see this change in terms of the general media, or have you just accepted that this will always be the case, and as long as you treat your patients well, it's fine?
I think there is, you know, there's a lot of Facebook groups for GPs, and we all get really, really cross about this, because it does demoralize, you know, us on a day-to-day. But I think it's not healthy, being the head of the GP school and seeing GP trainees come up. It's not healthy for our upcoming GPs to be seeing this kind of negative portrayal. And we very, very clearly say to them, you know, you need to actually not read that kind of social media stuff, and try not to read the press. But obviously the younger generation, that is part and parcel of their life. That is how they communicate with each other. So it's very difficult for them to completely take away the information coming from the media on social media. And that's very demoralizing for people to see that maybe general practice isn't what they thought it was, or that's what they're seeing in the media. And actually we're trying to say to them, it is good, it's great. Obviously there's always ups and downs, as there is with any job, but generally, you know, you do your job well, your patients will always feed back to you. And it's a very satisfying job. And it's one of the jobs where you can do so many different things with general practice. It's a great job for longevity in your career, I think. If you want to do 40 or 50 years, general practice is a great way to do it, because you can add so many things to your portfolio. But it's not great for our young doctors to be seeing such negative kind of information about them in social media.
I mean, there aren't any sort of pressure groups or sort of political activism that's there to support GPs and GPs' interests.
There are quite a few groups, I think, that have been set up. I mean, there's some Facebook groups, sort of like Resilient GP, GP Survival, DA UK, that are doing great work in pushing for all doctors, actually, but some of the groups are specifically for GPs, to try and push back, you know, when we get such negative media. But I don't think it's, you know, this is coming from top down, and almost you need something from top down supporting us. We will do what we can to push back, but at the end of the day, we are doing a day job as well. So it's, you know, it's a difficult thing. Keep doing that unless you have activists that do it full time, and we haven't got enough GPs, so GPs need to do the work. So, you know, top down needs to be that actually we are doing a lot of work. We are supporting our patients. We're not hiding. We're trying to do the most efficient thing we can to see as many people as we can and deliver that service, you know. So it's like you said, it's leadership at the top. It's, you know, what are they telling the public at the top? You know, what, you know, is there honesty in what they say? And often we've seen that's not really the case often. So that's really not great for GPs at the moment. And that's why we kind of decided to go, okay, we'll do what we can, but then we've just got to get on with our job. You know, we can't be ingrained in this, because it's not great for us to feel like
draining.
that. yeah, it's extremely draining. So yeah, we choose sometimes to ignore that bit of information through the media, really.
Yeah, yeah. And sort of like going forward, you know, we do have a shortage of GPs. I mean, do you see it sort of changing, or do you see it getting worse? I mean, you know, given that you've got your finger on the pulse, so to speak.
Yeah, I mean, we are training more GPs than ever before. The numbers have gone up exponentially over the last 3 years. You know, we've got funding to get more GPs into GP training. So that's been great. The trouble is there's a mismatch between how many people are going into GP training and then how many people are coming out the other end and actively working. And I think sustaining full-time jobs in general practice with potentially 10-hour days is really quite difficult. And I think a lot of the younger generation are saying, actually, I can't sustain that level of working. I can't do a 5-day job with 10-hour days. That's just not reasonable for me to be able to do that. So they're opting to do less days. So when people say I'm a part-time GP, I think people think that as a part-time office job. And it's not. GP days are 10-hour days. You know, we start at 8, we finish at 6:30, you're on call. A lot of people are staying later than that to do paperwork and you know, follow up on stuff. So, you know, the day's extremely long. So being a part-time GP might actually mean if you work 3 days, you're working between, you know, you're working 30 to 40 hours a week, which, you know, in the scheme of things isn't a part-time job. So I think we have to look at what that looks like for young people. You know, that's really, really difficult. They're bringing up families, they're trying to pay off mortgages, which are, you know, cost of living is going up. It's a difficult scenario. So it's how do we make the job appealing for doctors to continue working in it and sustain it for, you know, 20 to 30 years. So not only are people not doing full-time work, at the other end of the scale, people are retiring early because they're burning out and they cannot sustain the workload. So we're losing at both ends. And that's the bit that I can't do in the GP school, and we can't do as deaneries and regions. That is something that's got to come from the top. You know, that's coming from the government, NHS England. How do we, you know, got to look at this? How do we stop this leakage of people, really well qualified, bright, you know, people that we've spent lots of money on training them, and they've spent lots of money themselves training. We don't want to lose them, you know, we want to keep them. So I think there needs to be, it's that word again, bravery and courage, to think about how we stop the loss. And it's not just in general practice, I think it's happening around specialities.
I mean, we've got a massive shortage of ophthalmologists, and, you know, the Royal College of Ophthalmologists have been, what's the word, badgering the government for more support and more funding and more infrastructure to allow us to train more ophthalmologists, because we're you know, we're very short, and the population's getting older and sicker. So, you know,
Absolutely.
it is a you know, all specialties, as you mentioned before.
Yeah, and we are recruiting, obviously we're recruiting, historically, we've always had doctors come from other countries and train. You came to this country when you were young, I came to this country when I was young. People are coming after medical school, before medical school, you know, at different times of their lives. And there's a slight worry that we're draining, you know, the brightest from other countries. Is that right? And then lots of people, you know, might train here and go back home, which is also right. You know, how do we match that up as well? You know, we don't seem to have got the mix correct in terms of how do we sustain this long term and make it something that's sustainable. So tricky. Lots and lots of tricky decisions to be made in leadership.
You know, I think for me, because I'm a bit of a I'm interested in personality and sort of the psychoanalytical part of existence, and I think the more you know about yourself, the more likely you are to make a better informed decision about what you want to do. And I think that's something I'd like to see, kind of, so to speak, educated more within you know, within mainstream education, you know, at a younger age. And I think free flow of information and free flow of labor and free flow of economic migration should be actually open to all. And I thought, okay, you know, we do need to have immigration laws and procedure and so on, because you do want to keep a control of populations and resources and so on. I mean, I understand that. But yeah, I mean, you know, more people, whoever wants to come, absolutely come in. You know, I mean, it's done wonders for me. I mean, if I stayed in Iraq, you know, back in the 70s, you know, I wouldn't have got the opportunities that I would have got here. And I think it's absolutely awesome that my dad took the courageous step of coming here and uprooting his family and, you know, starting fresh, so to speak. But
yeah, and my family were also immigrants, you know, came as doctors in the 70s. So, you know, this is not a new thing. It's been going on for many, many years. I mean, a large proportion of the NHS has always been, you know, people who have emigrated, you know, and come here for, like you said, better opportunities. You know, the skills offered may have been better for them, you know, and education. So something they may or may not have had in their home country. So absolutely, I wouldn't be here either if it wasn't for that. So I think,
you know, we are of the caring type, you know, which is what I'm trying to say, you know, is that our personalities per se attract towards these kind of professions. And I think maybe that's something that we can think about in terms of keeping our workforce sustainable, is that, you know, maybe this is what you're about rather than the job itself.
Yeah, I mean, you talked about coaching and facilitation. I've always maintained that coaching should be available, actually, to most doctors. I mean, in most private corporations, you wouldn't get to the level that you get to in medicine without having some coaching and mentoring. And it's amazing that hasn't happened over the years. It's starting to happen now. CCGs and PCNs have been setting up and training hubs, and have been setting up coaching and mentoring for doctors, and it's available. So, you know, we actively ask people to go. You know, if you're struggling or you're in a point of your career where you need to just figure out, go and get it. It will be useful for you to just have some time and reflection to think about what's going on, and it will stop you burning out. I think that's the key. If you go early enough, it will help you think about what you need to do before you get to that point of falling off the cliff, as it were. So yeah, it certainly helped me, having had coaching myself, but being a coach, I hope I'm helping some of those doctors think about what works for them, and help them stay in medicine a little bit, but not go out altogether, but help them think about what that looks like for them, you know, what's healthy for them, what will work for them, you know, if they want to keep working till they're 60, 65, what's the best way to do that so you remain fit and well and enjoying your roles and your jobs. So it's so important, rather than just being on this treadmill and just running and then falling off it because it's gone a little bit too fast. That's my kind of metaphor, really. And that's what used to happen, and it still does for some people, which is a bit sad. So yeah, I'm a proponent of coaching and mentoring, and I'm very keen that people go and do that if you're at that stage where you're unsure of what you're doing, where you're going, whether you're well enough to do things. And if your physical and mental health is suffering, it's definitely one of those things to go and do, I think.
And when was the first time you saw a coach, or you were exposed to the, you know, to the coaching phenomenon?
Yeah. So interestingly, in the as educators, we had something called an experienced trainers course, which you were encouraged to go to maybe every 3 years or so to sort of develop your skills further, you know, after you'd been training for a while. And the course had changed over many years. And when I went on the course, it then started being run by a coach in the support and wellbeing service. And she was running it, and the way she ran it is she had role play, and she taught you how to do sort of mini coaching sessions. And effectively, you were coaching trainees in need of support. So trainees that were going through difficult times, whether at work or home. And she taught us how to coach our trainees through that. So rather than giving them solutions and telling them what to do, it was helping them come to the realization themselves about what they need to do to help themselves. And obviously asking those coaching questions, a little bit of a challenge. and we had to practice on each other and on the role player, and feed back to each other and video ourselves doing the coaching. So it was all a bit scary, but also I came out of that course. I think that was back in, I don't know, maybe 2015, 2014, and thought, oh my God, this is such a good way of doing this. This is so much better than telling people what to do. This gets people thinking about it for themselves. And I loved it. And I thought at some point I'm going to do a coaching course. And then I went and did a mentoring course for the NHS and mentored a few doctors. And that was fantastic. And then I was going through a crisis about where I wanted to go next, and kind of, you know, do I want to stay in medicine, in general practice? Do I want to do something else? And I thought, do you know what? I need to go and see a coach myself to work through this. So I went and saw a coach myself and had about 4 sessions with a coach. And it was the best thing I ever did. It sort of clarified in my head some of my behaviors and why I was doing them, and how I was jeopardizing myself before I even did something. I was talking myself out of doing things because of, you know, stress or anxieties that I had. Neuroses, I love the word, neuroses about what I thought would happen. And I realized it worked for me. So I said, if it works for me, this will work for other people. I'm pretty sure. And I'm sure doctors go through it even more because we have such busy lives. We have got very important jobs, in the sense that very busy jobs, but also with a lot of responsibility. And we worry about these things all the time. But we also worry about how long we're going to be able to sustain that work, and, you know, what we're going to do when we get into our late 50s or 60s, you know, what's going to happen. So I decided to go on a coaching course, and I did my ILM5 coaching and mentoring course at Oxford Brookes, and had a fantastic group of supervisors there, and a group of people that I still keep in touch with, my peers and colleagues. And since then, I've used coaching in absolutely everything I do. I've used it with patients, I've used it with colleagues, I use it in my head of school role when I'm doing appraisals, and it works. You know, that method of getting people to take a bit of time out and reflect and do it, it works. So for me, it's the way forward. And I still do some private coaching, and I've had a few doctors and non-doctors as well, but professional people that I've helped kind of with their crises as well. And I just love it. I'm a proponent of it. It works on me. I've had feedback it works on others, and it's almost like it's a life skill to me almost. I've used it on my family. I've used it on my children. So yeah, absolutely.
Yeah, I mean, as they say, you know, the most important thing is not the answer, it's the question. You know, it's all about the question.
Yeah, absolutely. And it's a safe space where you can ask the questions, challenge someone a little bit without them feeling worried about it, and it's their space, you know, it's their time. And that's the main feedback I get is I never have time, like an hour, to just sit and reflect on my life and think about what I'm doing and why I'm doing it. And the very fact you give them that space to do that is in itself the therapeutic element sometimes, I find.
Yeah, you know, the whole I mean, it is an intimate relationship, and you know, we do heal in these relationships, but we don't know why it works. I mean, I don't know why it works. I mean, you know, there is no science behind this, but it, you know, it's and it's difficult. You know, I've worked in the therapeutic space, the psychotherapeutic space, for some time, and it's difficult to explain it scientifically, you know, because the psychometric tests are kind of giving a scientific flavor to it, but there's not much empirical science there. So it doesn't really talk to the empirical, you know, the absolute empirical scientist, which is why some people kind of treat it a bit, you know, maybe that's reluctance why, you know, not all doctors, you know, get into this thing about coaching. I mean, I remember when I was sort of promoting my service in coaching, and I got all kinds of funny, you know, coaching, no way. It's like, oh, not for me, thank you very much. It was quite interesting. Maybe it's a surgeon thing. Maybe it's a surgeon.
I think you're right. if you're a scientist and an uber scientist, if you're a surgeon, obviously everything is very evidence-based. It has to be by its nature, hasn't it? And I think that's why doctors, because everything is so scientific, and our opinion has to be based on scientific evidence, hasn't it? However, as GPs, I think maybe there's a little bit, we're a little bit maybe more open to it, because a lot of what we do is based on our intuition and our gut, and we know that person and we know there's something not quite right, but we act, and then we look back and go, now I know why that happened. But at the time, there's no scientific reason sometimes why you feel some way about something. And so it's that it is based on your experience, and it's based on what you've seen before and how you've seen it. But in the moment, it feels very emotional. Something is not quite right with this patient and I must do X, Y, Z, but you cannot pinpoint the evidence behind that. Everything might be normal. Their OBS might be normal. They might seem normal, but in context of that person, they're not compared to what they were. So that's why I think lots of GPs go into coaching or use coaching. And I think we're maybe a bit tuned into that bit. Yeah. But I agree, a lot of people would say, what's the evidence behind coaching? And particularly if you say life coach, everyone just recoils in horror, because it's sort of, oh my Lord, what does that mean? And I recoiled in horror when someone said that's what I was. And I still quite haven't worked out what kind of coach I am. And I sort of still resisted calling myself any specific kind of coach, because there's connotations to what you call yourself, I think. And it's interesting, isn't it, people's reactions to that, particularly medics, I think. They sort of...
I mean, that's going to change though, because, I mean, if the head of the GP school is doing coaching, I think that's that's a great sign of the change of times, and it gives other people permission to go into that sphere, and at the same time, be empirical and scientific. So, you are sort of being the pioneer and bringing the soft and the hard together.
That's a good way of looking at it, and I think that's what we do as GPs the best. We bring all the hard evidence. I need to check your chest and I need to do your oxygen sat, but the softer skills are, I understand why you're feeling that way, or you didn't feel that way 2 days ago. What's going on in the background? What else is causing you to feel unwell? So I think it's part of our role. We're human beings with emotions, as well as having a brain that understands logic. So the two aren't completely separate. They always have to combine, don't they, and work out what is important and when.
I think having that sort of, having that integrated structure is really important. We've got the cognitive structures, which which is very empirical, but then we've got the hippocampus, which is very archaic and very powerful, and it can shut off all of the cognitive abilities very quickly. So I think we shouldn't dismiss the softness of our skills at all, because I think that's much more powerful than the hard skills, and I think they they do come first, and this coming from a surgeon, so that's not too bad.
That's very good. You're a surgeon who's had a different kind of a trajectory, though. So,
well, I mean, I think I've got a strong ego. I'm quite narcissistic, and I think that's why I became a surgeon. But then I realized that I'm not that, and I'm kind of retracting back from my hard empirical existence and becoming more myself, which is this sort of soft, fluffy thing, but trying to act hard sort of thing. But
there is something about you are made to be something, aren't you? That's the other bit, is that part of applying for medical school and going through the process and being a surgeon, the long kind of years that you have to do that, you have to form your hard core so that you can get through all the difficulties that actually medicine throws at you. And I think when you're older, you're a bit wiser, and you can look back and reflect and be able to soften those things, because you've been through that bit. It's very difficult when you're going through it, though, isn't it, to relax.
Well, I mean, I stopped thinking about what other people think, so to speak. Really. I mean, that's what time has allowed me to sort of realize, is that it's actually okay what they think, and what's more important is what I think about myself rather than what other people think about me.
And that's such a relief, isn't it, when you come to that realization that, oh, well, it doesn't matter what they say. I know what I want to do and want to say and how I am. And so you may not agree with me, and that's okay as well. We all have our opinions. As long as your opinion of yourself is robust, and you've got that self-confidence, self-esteem,
I mean, as long as it's not a lie,
through.
I think that's really important. I mean,
Yeah.
you may not actually know who you are and what you are and sort of the truth, so to speak. But I think what's really damaging is that you lie to yourself, and who you are and who you think you are. And we all know when we lie. I mean, we can't tell when other people lie. I mean, no one can tell what other people, when they're lying. But most people can tell when they lie to themselves. They get that horrible feeling inside, and that's when you need to act. And luckily for us as human beings, we are beings of action and movement, and I think there's a lot of wisdom in that. And if we can bring the whole this whole process of movement and action into healthcare and exercise or whatever you want to call it, I think it will benefit a lot of people, rather than reaching for the first nice approved therapy that is currently being funded by all the pharmaceutical companies. Anyway, let's not get too political here. I mean, we could have another session about that, and also, I mean, we didn't talk about racism, which is a big thing, and it's got a great flavor now, and it's become very sexy and sort of very sort of everyone can talk about it and sort of have a great opinion and so on. Maybe for another session we can sit down and just talk about that for about an hour, because that'll be quite interesting. Yeah, that would be really interesting. So let's finish up by sort of asking you this sort of question I ask all people really at the end of the podcast. What are the 3 sort of top tips you would tell yourself who's about to start medical school in? You were in Cardiff, wasn't it? Sort of medical school.
I was in Cardiff. Yes.
This was 90. What was it? 90.
So I finished in 1997. A long time ago now.
Yes. So 1992 you started, I imagine. Yeah. So you're about to start medical school. You're about to go to Cardiff. What would you advise your younger self? What are the 3 top things you'd tell yourself? In a coaching way, of course. In a coaching way.
The 3 top things I would tell myself is failure is not the end of the road. I got into medical school, but I wasn't the best student, let's put it that way. And I learned from my failures. So failure is nothing to be scared of. It's inevitable. Everyone will have some failures. And I think learn from them and move on, I think, would be one of the tips, really. My second tip is try and enjoy your life. I mean, I certainly enjoyed medical school. I'd only come into the country a couple of years prior to it. So I made long-lasting friends. I felt like I integrated into the country, which prior to that I didn't feel I had. While still keeping my own culture, I felt like I felt more like I belonged. So that's my second tip, is that enjoy the time. You never get that time back again. And with the wisdom of old age, I can say that was, one of the best times of my lives, and I really enjoyed myself. So that's my second tip. I think my third tip is sort of, and I try and live my life a little bit like that, is that don't put off things for the future, or things that you might be able to do today for a future day. Because absolutely life is short. And if COVID has taught us anything, is that it's extremely unpredictable. And I don't leave things till I retire, or I'll travel there one day when my kids have left or whatever. I try and do what I can myself with my family, and take everyone with me, and try and do the things I enjoy, because absolutely life is short, and I have no idea what's going to happen tomorrow or the day after. So I try and live my life the way I want to live it, rather than it being dictated by anyone else.
That's beautiful. It's been absolutely awesome speaking to you, and we should do another session about just talking about racism. I think that'll be quite
I
interesting.
think we will.
And see you in the social media world, I guess.
Yes, I guess. Hopefully not too much though.
Not too toxic.
Keep our mental
Not too
health.
toxic.
Yeah, exactly. But it was
All
lovely
right.
to talk to you, Heather.
Take care. Bye-bye.
Take care. Bye-bye.